Hi everyone, welcome back. In this video, I'm going to talk about the congenital adrenal hyperplasias. This is also known as adrenogenital syndrome because the symptoms affect the adrenal gland as well as the genitalia. And I'm going to help you distinguish the three main types from each other by the end of this video. All right, so here's a quick overview of this talk, and you can check it out here. One thing I'll say is that I will start with a quick recap of the adrenal cortex, but I recommend that you actually first watch the video on adrenal cortex physiology because you need to be familiar with the different zones of the adrenal cortex and the hormones that they produce. Let's get started. All right, so let's start with our recap of the adrenal glands. So these are two glandular structures that sit on top of each kidney, and they produce hormones that are vital for life. And these hormones depend on which layer we're talking about. So the central layer, which is the adrenal medulla, secretes epinephrine, which is the main hormone of the sympathetic nervous system. The peripheral or outer layer is the adrenal cortex. And this layer itself has three separate zones, which are the zona glomerulosa, fasciculata, and reticularis. And these all secrete steroid hormones, but different steroid hormones in each zone. And this is what we're really going to be focusing on right here, the different zones of the adrenal cortex, because this is the area that's going to become problematic in congenital adrenal hyperplasia. All right, so let's go through each zone. I'm going to start out to in. So the outermost zone is the zona glomerulosa, and the hormones that are made here are called the mineralocorticoids. And the three mineralocorticoids are aldosterone, corticosterone, and 11-DOC. And from these, aldosterone is the main mineralocorticoid, but you should know that these other two also have mineralocorticoid activity because this is going to become important later in one of the diseases that we're going to talk about. Mineralocorticoids have three important actions. They increase blood pressure, decrease serum potassium, and increase serum pH. Next, let's talk about the zona fasciculata. This is the middle zone, and the job here is to make glucocorticoids, mainly cortisol, and cortisol has lots of different actions in the body, including increasing blood pressure and increasing serum glucose. And then finally, the last zone is the innermost zone, which is the zona reticularis, and this zone is important for synthesizing androgens, which are male sex hormones, and the main ones are DHEA and androstenedione. And the main actions of these are masculinization as well as promoting puberty. All right, so now that you know about the adrenal cortex and the hormones, let's learn about the disease, which is congenital adrenal hyperplasia. So the problem here is an inherited enzyme deficiency, and in all of these different types of it, the problem is going to be inherited through autosomal recessive pattern. So all of these are autosomal recessive, and they're all going to lead to a decrease in production of one or more steroid hormones in the adrenal cortex. And in response to that, the adrenal cortex is going to compensate. There's going to be more ACTH because there's less cortisol, and this is going to lead to enlargement of the adrenal gland. And this is why this is known as congenital adrenal hyperplasia. So congenital because it's present at birth, and adrenal hyperplasia because the gland is enlarging to compensate for the enzyme deficiency. And there are three main types of congenital adrenal hyperplasia depending on which enzyme is missing. So in 21-hydroxylase deficiency, these two reactions are going to be inhibited right here. In 11-beta hydroxylase deficiency, these two reactions are going to be inhibited. And in 17-alpha hydroxylase deficiency, these two reactions are going to be inhibited. And all three of these cases, cortisol levels are going to be low. So if you know that you have a congenital adrenal hyperplasia, you don't have to worry about what's happening with cortisol. You know that it's going to be low in all three of these. But what's different between these three is what's happening to the other two hormones, which are the mineralocorticoids made in zona glomerulosa and the androgens made in the zona reticularis, because that depends on which enzyme is being inhibited. And so that is what you're going to use to figure out which enzyme deficiency you have based on whether your mineralocorticoids are up or down or your androgens are up or down. And we're going to go through each of these now so you can see. All right, so let's start with 21-hydroxylase deficiency because it's the most common type. More than 90% of the cases are due to this enzyme deficiency, and it's so common that it's part of the mandatory routine newborn screening of all babies in the US. So what's going to happen right here is this reaction is going to get inhibited. Therefore, we're not going to make any of our mineralocorticoids, and therefore mineralocorticoids are going to be very low in these patients. What's going to happen over here in the zona fasciculata is you're not going to have this reaction of going from 17-hydroxyprogesterone to 11-deoxycortisol. So you're not going to make any cortisol. You're not going to have glucocorticoids. So those are going to be low as well. And so what's going to happen then is that the androgen levels are going to be high because all of these steroid precursors are going to be shunted to this pathway right here. And again, since we don't have cortisol, we're going to have upregulation of ACTH. So we're going to have more activity, and all of that is going to be shunted this way. So the net outcome is going to be low mineralocorticoids, low glucocorticoids, and high androgens. And then finally, the substrate here is going to be very elevated, which is 17-hydroxyprogesterone. The reason that I mentioned this is the lab value that they actually use as the screening test for newborns. So it's checking the levels of 17-hydroxyprogesterone, and it's going to be very elevated in patients with this enzyme deficiency. And then final point is that sometimes exam questions want you to understand the fact that since the mineralocorticoids are going to be low, that means blood pressure is going to be low, and that means due to loss of negative feedback, these patients are going to have high levels of renin to try to bring up the blood pressure. And we're going to see the clinical side effects of this condition on the next slide. All right, so let's talk about the clinical presentation. So how are you going to know that a patient has 21-hydroxylase deficiency? There are two different types of this condition depending on the severity of it. And the classic type is more rare, but it's the one that's more commonly tested. And that's because it's the severe version. So you're going to see all the clinical manifestations of this enzyme completely missing. So I'm going to go through this one first. So the problem here is that it's severe because there is no enzyme activity. This enzyme is not functioning at all. So obviously this is the one that's going to present earlier on, and usually it's going to be a newborn that you're going to see this in. And because this newborn doesn't have any mineralocorticoids or any glucocorticoids, they're going to lack all the effects of these hormones. So sodium and blood pressure are going to be low, serum potassium is going to be high, and serum glucose is going to be low. And this characteristic finding of refractory hypotension with these classic labs is known as an adrenal crisis. And this truly is a crisis because it is life-threatening, and the treatment is with IV hydrocortisone, which is a type of steroid that has both mineralocorticoid and glucocorticoid action. The other problem here is that you have very high levels of androgens being made in the adrenal cortex, as we just explained, and this is going to be a problem in females because when they're exposed to this in utero, all of these high adrenal androgens is going to lead to masculinization of their genitalia. So females are going to be born with atypical genitalia. Obviously, this is not going to affect the males because their external genitalia is already masculinized due to their own androgens from the testes. The more common type is the non-classic, and this is milder because the main difference here is that there's some enzyme activity. So mineralocorticoids and glucocorticoids are going to be made to some degree. So these patients are going to have normal blood pressure in labs. They're not going to have these adrenal crisis symptoms here. The main issue here is going to be some level increase in the level of adrenal androgens, but not as high as you saw here. Therefore, there's not going to be any newborn masculinization, but this is going to really present later on in childhood as precocious puberty in both males and females due to the higher level of androgens. And then finally, females are going to be at risk for hirsutism and infertility, again, due to the higher level of circulating androgens. All right, so let's move on to the next one, which is 11 beta hydroxylase deficiency. So let's find the enzyme here in our zona glomerulosa. So here we're going to be inhibited, which means that our mineralocorticoids, which are corticosterone and aldosterone, are going to be low, but that's only half of the story. Because remember, I said that 11-DOC is a mineralocorticoid as well, and I said that it's going to be important later on. Well, this is where it's important. 11-DOC is going to be elevated because it's the substrate of this reaction which isn't happening, and these levels are going to be so high and super physiologic that the net effect on mineralocorticoid activity of this enzyme deficiency is going to be an increase in mineralocorticoid activity due to the very high levels of the built-up 11-DOC. In the next zone, the zona fasciculata, we're going to have inhibition of cortisol synthesis, and so levels are going to be low. This is the same in all three of these enzyme deficiencies, as I mentioned before. Then finally, just like we saw in the last case, the androgen levels are going to be elevated because these precursors are going to go down this pathway right here and have more DHEA and androstenedione. So the clinical findings here are you're going to have high levels of mineralocorticoids due to the high levels of 11-DOC. So the findings are going to be the opposite of what we saw with the classic 21-hydroxylase deficiency, which was the last case. So here blood pressure is going to be high and serum potassium is going to be low due to the high mineralocorticoid activity. So this is the key way that you can distinguish this one from 21-hydroxylase deficiency. The second problem is the high levels of androgens. So this is the same as we saw in the last case. Just like in 21-hydroxylase deficiency, the androgens are high. So at birth, females will have atypical genitalia due to masculinization, and then puberty will be precocious with findings of excess androgens such as hirsutism and acne. All right, now let's talk about our final enzyme deficiency, which is 17-alpha hydroxylase. So let's take a look at it here on our little diagram, and we can see that if this enzyme is deficient, then all the action in the zona fasciculata and reticularis is not going to happen, basically. So all the action is going to go on in the zona glomerulosa. So what that's going to mean is high levels of mineralocorticoids, low levels of cortisol, and low levels of androgens. And so the clinical findings here are going to be due to the high levels of mineralocorticoids, we're going to get high blood pressure and low potassium. And this is exactly what we saw in the 11 hydroxylase deficiency, which was the last case. However, here, unlike the other two enzyme deficiencies where they had high androgens, here we have low androgens. Therefore, the clinical findings are going to be the opposite of what we saw in those cases. So at birth, females are going to have normal genitalia, whereas males are going to have atypical genitalia and undescended testes. And at puberty, instead of having precocious puberty, we're going to have delayed or absent puberty due to the absence of the androgen influence. The one thing that may be confusing is why are the males going to be affected with having atypical genitalia due to the loss of the androgens in the adrenal gland if the male's testes should still be producing testosterone. And the reason is that the male's testes is not going to be able to produce testosterone because the testes uses the same enzyme 17-alpha hydroxylase to make testosterone. Therefore, in males in this condition, not only can they not make the androgens in the adrenal cortex, they're also not able to make testosterone in the testes because they're missing this enzyme. And this is why they have atypical genitalia. All right, so here's a summary table comparing our 3 enzyme deficiencies and everything that we talked about in this video with the cortisol levels, mineralocorticoid levels, and androgens and what's going to happen with each of these cases. So you can review this. But what I wanted to point out here was this mnemonic that's super helpful in remembering what's happening with these enzyme deficiencies. And this was around back even when I was a med student. So the way I would write this is write each of the enzymes like this, and then underneath it write blood pressure and the androgens. So what's happening to the blood pressure, aka mineralocorticoid activity, and what's happening to the androgens. And if you write it in that order, you'll notice that wherever the number 1 lands in the enzyme deficiency, those levels are going up and the other one is going down. So that means that in 21 hydroxylase deficiency, blood pressure is down and androgen levels are up. In 11 hydroxylase deficiency, they're both 1, so both blood pressure and androgens are elevated. And in 17 hydroxylase deficiency, the blood pressure is elevated and the androgen levels are down. So this is going to be a very easy way. If you just remember this order right here, it's going to quickly help you remember when you see 21 hydroxylase deficiency, boom, that means androgen levels are up and blood pressure is down. If you see 11, that means both got to be up. And if you see 17, that means blood pressure is up, androgens are down. Okay, that's it and that's all. If you guys enjoyed this and thought it was good, please share it with others and don't forget to subscribe so you don't miss out on upcoming content. But for now, thank you for watching and I'll see you next time.